Thank you, Zach. If we could call this meeting to order, please stand and we'll say the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. You may be seated. Welcome. It's a beautiful day and we're glad you're here. I'm Mark DeGroff, president of Downtown Rotary, and it's my pleasure to welcome one of our very own, Karen, who heads the team here that's hosting us. And she's going to share with you some of the exciting things that are going on in Midland and officially welcome you to their facilities today. Karen?
Thank you. Thank you. Well, we are delighted to be able to host this today, and what a beautiful day it is. We couldn't have asked for a nicer day. For those of you who have not been here before, one of the most important things is where are the restrooms, and they're right down that hall right there. For those of you who have been here, we welcome you back. We hope that your experience with Midland was memorable. And you know, that's what we do here. We create experiences and memories for people. Because all of us face some tough times, and at Midland Care, we want to support patients and families to the best of our ability to make that experience and those times as healing as they can possibly be through the process. Whether that's someone dealing with aging, as in our PACE program and in our small assisted living that we have, or whether it's in our home health or our hospice program or our palliative care program. We are growing. Today on service, we're taking care of 653 people. And some people are just amazed to hear that. And I gotta tell you, I've been here for almost 30 years and I'm amazed to hear that. Because it's just happened one patient at a time as we've responded to the needs that we've seen in our communities. And around the room you will see some designs for our new building and some changes to our hospice house. We're going to be moving to a new building over on Westport. It will be our new Center for Senior Independence. It will serve our PACE program and also provide for Meals on Wheels. Meals on Wheels is also growing. You know, today we're serving about 1,000 lunches. We've just recently expanded over to Lawrence and added 100 new meals a day over in the Lawrence area. So again, responding to the needs as they come to us. And we are just so delighted that we have such great community support from many of you in this room and from others out there who have for years been supporters of Midland Care. It allows us to continue to serve people regardless of their ability to pay, which is a really important part of our mission and vision here, to be able to touch more lives and to provide the care and service that they need. So again, on behalf of all of us at Midland Care, I welcome you today. If you don't know about us, we would be glad to talk to you a little bit more about the services that we provide. But we did free up some parking for you today, because one of our problems is we don't have enough parking anymore. But thankfully the cemetery next door allows staff to park over there when we need to, as we have done today. So thank you for coming out and sharing the day with us, and I am proud to be a member of this Rotary Club.
Thank you, Karen. Now Zach Aarons is going to do our Rotary Minute and guest introductions. Zach?
All right. Well, for guest introductions, we have 70 people that are guests here on the Midland campus, so if you would all stand. We have, with our record, one guest today, and that is Betty Morris, who is a guest of Anita. So, Betty, if you would stand up, please.
Hi, Betty.
Glad to have you here, and I have more good news. Our president, I believe, I saw an envelope that has an application for membership. And so we are pleased to hear it. Yes, another round of applause. So that is the first official reading of your name for consideration of membership. And now for our Rotary Minute. Rotarians all over the world are working and serving and living out the four-way tests. And as you know as Rotarians, there are 6 main focus areas. And one of those focus areas is fighting disease. Our health is everything, yet 4 million people in this world can't afford or don't have access to basic health care. Disease results in misery, pain, poverty for millions of people over our globe. But here's good news. As Rotarians, we are part of an organization that combats disease like malaria, HIV, AIDS, Alzheimer's, multiple sclerosis, diabetes, and polio. And as Rotarians, we make health happen. In fact, we educate, we equip communities to stop the spread of disease that threatens life. And as a movement, we've made tremendous impacts on these diseases. And I know you've heard it before, but I think it's important this morning, especially as we focus on health. That is Rotary Foundation. You are a part of $65 million in grants to help provide fighting against disease. And we make these things happen by providing clean water, reducing HIV infection, ending polio. And so as Rotarians, we're now part of this movement that really does inspire people to move from education, prevention, to eradication of these diseases that are costing the lives of children and mothers and families and people all over our globe. So thank you for your commitment and service to Rotary. That's your Rotary Minute and a half.
Thank you, Zach. We have a couple of quick announcements. Our October featured charity is the Guatemala International Service Committee, and that continues with cut money to purchase paint and supplies to repair the school and the medical facility that our team went down to work on in July for the international service trip with the Pica South Club members. We have a few other announcements. Andy Tompkins and Carrie Norberry have a quick announcement here about an upcoming exciting opportunity and some volunteers. Andy?
Thank you. Well, this is my year to try to get you excited to come and volunteer and help at Washburn Tech. So many of you know we've had a history of going to help middle school students who go to Washburn Tech for a visit. Normally that's been in April of every year. This year it's going to be during American Education Week in November, 13th, 14th, and 15th. And to just give you an idea about this, so there's 2 sessions a day. There's about from like 8:30 to 10:30 in the mornings, one session, 12:30 to 2:30 in the afternoons, another session. So we have 6 sessions. And we're bringing 8th graders from each of the middle schools to Tech in order to get a visit, a kind of a college visit opportunity. The district has worked with Washburn Tech to kind of come up with a new theme for this and how they're working towards this, because the 8th graders have to put a plan in place. Some of you know that for when they go to high school, so they thought this would be a perfect time to start doing that. So we have, just to give you an idea, we'll start bringing some posters with some sign-ups, because our smallest group that's coming on one of those sessions is 154 students. And one of our largest groups is 204. So we have 6 of them, so you go ahead and do the math. We got a lot of kids coming. They'll be the ones doing the touring and all that. All we do is just walk around with the small groups. They probably do small groups to the tour. But so your job is nothing but showing up and walking around with the kids, but we hope you'll sign up, and we'll get some sign-ups to you for that. So thank you very much.
We also have a list of volunteers for mentoring with Highland Park High School, and lately there's been some more amazing traction with that. So if you're interested in doing that and haven't done it before, I would encourage you to contact Lee Morris. And if you've done it before, you know how meaningful that is to those kids, and encourage you to engage again. World Polio Day in Topeka is October 24th. Activities start with a program around 11:30. That runs until about 1 o'clock, and then there are guided tours of the Capitol and guided tours of the Dome until about 3:30 that afternoon. There is a walk for polio that's 1 block, so no excuses on that one. And we are asking Northeast Kansas Rotarians and family members to register for a chair. And you can do that or register the number in your family on our website. The District Foundation Banquet is coming up as well. It's November 3rd at the Overland Park Sheridan. If you have questions about that, please see Blanche Parks. We are recruiting for outbound youth exchange students to study abroad for the 2019-2020 school year. Details are on the club website, or see David Beck, who also, by the way, manages that for our district. And so we're fortunate to have him in our home club here and have him managing that in the district as well. Invoices for fourth quarter have been emailed and mailed. If you didn't receive one, check your spam folders. And if you would like one sent again, let us know. Just send an email to Linda and me as well. Linda is recovering well from rotator cuff surgery, and I believe today was her first day in PT. So we wished her well and sent her off with good thoughts. Lastly, Larry Dimmitt has done it again with his international service. and he needs a Spanish to English and English to Spanish translator. So if any of you speak Spanish fluently and English, that's the kicker, he would love to hear from you. So please contact Larry. And if any of you don't speak Spanish fluently and English, but know someone who does, I think he would love to have their phone number as well.
I might just add that he doesn't need that translator anymore. He's down there in Mexico, and they ask him please to speak English because there's a translator right beside him.
There you go, late-breaking news. I was good in most of Europe on Spanish until I got to Italy, and then the first sentence was Italian, and after that it was something very wrong. So I can relate. And with that, it's my pleasure to introduce Doug Scott, who will introduce our speaker today. Doug?
Greetings and thank you. It is my pleasure to introduce Matt All, President and CEO of Blue Cross and Blue Shield of Kansas. Matt is actually our 8th CEO with Blue Cross and Blue Shield. I've had the pleasure of working with 7 of those 8. I started when I was 2. But I will say Matt joined Blue Cross in 2006. He was our Vice President of Legal Services and General Counsel. He took on a whole host of other responsibilities over the first few years he was with the organization. It helped groom him, build him, if you will, know more about our organization and the people we care for, and has put him in the position today. He was deeply engaged in our development and success under the Affordable Care Act. You may recall back in 2010, there was all kinds of new stuff coming through Obamacare, and Matt helped guide our organization to success and get us ready for that. Prior to joining Blue Cross Blue Shield, he was in private practice for a number of years. He was in state government as Assistant Insurance Commissioner. He also served as Chief Counsel to the Governor. Closer to home, he's involved in a variety of community activities. He's on the board of United Way of Greater Topeka, University of Kansas Honors Program Advisory Board. He's a standing lecturer at the University of Kansas School of Law, where he teaches insurance law. He supports the fields, he sings, he acts, he does it all. He also spends time with his kids and their friends, coaching Little League, softball, baseball, soccer. Raised in Augusta, he's a Kansas boy, so he's earned his bachelor's degree from the University of Kansas, his law degree from Yale, lives in Lawrence with his wife and kids. My pleasure to introduce Matt.
Okay, so I guess I need this. I've been told that I'm a, would you call me a random wanderer? Something like that. That's the nice way to put it. All right, I guess we're on. Okay, so thank you, Doug. Thank you to all of you for allowing me to come back. I was here speaking, I think it was a year and a month ago. Ira introduced me then and made up a whole bunch of nice stuff, actually. And so you asked me to come back, and so last time I gave a talk that I called Healthcare Policy, Ideas, Reality, and Politics, because I can stand up here and give you a commercial about Blue Cross. I'd love to. I'd love working there. I believe in what we do. But I don't think that's what you really want to hear. There are a lot of public policy and political issues revolving around healthcare, and I think that's what we as citizens ought to be talking about. So I went back to my slides, and I decided I would give you the 2018 update. Now, I had several other titles. I had, like, Part or Episode 2. I also had Episode 5, Obamacare Strikes Back. That didn't really make a lot of sense. So we'll stick with this. All right, so I'm going to go through the ideas really quickly. A lot of those are the same as what I talked about last time. There's a few other ideas that I threw in there, but it's basically the same. But I think it's important to keep talking about the fundamental ideas about healthcare and about insurance, because this is an issue that we need to solve as citizens, as a country, and it's important that we have an adult conversation about it. And so it's important that we understand it. So I'm going to go through those quickly. I'm happy to stay and answer questions after that. I'll go through the reality and kind of the change to reality a little bit, and then we'll talk just for a minute about the politics. I know I've got a hard stop at 5 till, so if I talk too fast, I apologize in advance. I have a lot of things that I want to say. Okay, so to begin with, there really are, in the ideas section, 2 basic issues when it comes to health care. And this has been true for decades. So you have availability and you have cost. So availability, for too long, and still today, there are too many people who do not have affordable health care available to them. And for some, before Obamacare, there really wasn't any health insurance coverage available to them at all because of whatever circumstances they were in, because of their job and their economic situation and their health. Many of them couldn't get care covered even if they wanted to. The cost issue is that it's unaffordable for too many people, and the costs are going up unsustainably. And that's been true for decades. That was true in 1970s, true in 1990, and it's true today. We're spending more and more every year. So the ACA really dealt with this first issue, with guaranteed availability, with subsidies, with the standard products and so forth. It made healthcare available to a lot more people. What it didn't really deal with directly, there are a few things on the periphery of the law, what it didn't really deal with is the cost issue. And that is really the fundamental problem that we have in healthcare, the perennial problem, that if we don't solve, we can make it available nominally to everybody, but until we get costs under control, it's still going to burden us as a country. So, to deal with the cost issue, we need to think about what the scope is. So this is one way to measure it, which is how much of our economy does it take up and how has that changed over the years. You see back in 1970, it took up about 7% of our economy. It grew to about 9% by 1980. You see what 12% by 1990, flattened out a little bit in the 90s, and then jumps further to the point now where we're almost 18% of our economy, and it's still increasing. I don't know what's the right percentage. I don't know if it's 15 or it's 20. What it needs to be is sustainable so that it grows, but it grows with the rest of the economy, along with wages and the rest of the GDP. So what you need to know about it is that the bulk of that growth, the highest rate of growth, were in previous decades. We lurched ahead of the rest of the world in the 70s and 80s, flattened out a bit in the 90s, grew too fast, frankly, in the 2000s. It's been closer. We have made progress on this, so there is some good news. It seems like anything that's involved in politics, we have to talk about it as if it's irreparably broken, and it's not. We are making progress in getting costs under control, but we're not there yet. So this shows GDP in green, health spending in blue. Those bars need eventually to be at the same level, where healthcare is growing along with the rest of the economy. We're not quite there yet. Now, one of the things we like to do about healthcare is beat up pharmaceutical companies, and I promise you, I am not here to defend pharmaceutical companies. Believe me, I'm not. But it's important to have the numbers straight in our head in order to get this right. So what this shows is that prescription drugs grew faster than the rest of the healthcare industry in the 80s and 90s and last decade, but they've actually slowed quite a bit to the point where they're growing at about the same rate as the rest of the healthcare industry. And they're growing, and they're also a smaller part than the two other really large parts of the industry, which is hospitals and physicians. So we spend about a dime out of every dollar on prescription drugs. We spend a lot more than that on hospitals and doctors. That's not to say that they are the problem either. It's just to say that if we're going to solve this problem, now, I'm not here to defend drug companies, but they seem to be the focus of a lot of our debate, and they've earned that, believe me. But it's important when we're talking about healthcare policy that we not make policy based on ugly anecdotes, all right? They've earned their reputation in many ways, but we're going to have to deal with this entire pie if we're going to solve the issue of healthcare costs. Okay, here's something you know. It's not a slide I like to put up, but it's something we must face as a country. We spend more per capita on healthcare than any other country. It's not even close. Now, I will tell you that some of these countries are beginning to gain on us, Switzerland in particular, but we still spend a lot more, and we don't necessarily get more for that. All the rest of these countries, if you get your knee replaced, if you have a hospital stay, you're going to get great care in those countries. We just spend more for it in this country, and that has to get better. Now, the other thing you need to know is that those countries are beginning to gain on us a little bit. We have slowed our rate of growth. It's still too high, but other countries' rate of growth has actually caught up and actually surpassed ours this decade. And so let's not necessarily say that they're doing anything wrong, but what's interesting to me, what I wonder, in 2025 or 2030, what will the French and the Germans and the Swiss be saying about their healthcare system? Will they be having, even though they have different types of systems, some of them are more similar to ours than you may realize, but what will they be saying the same types of things about their system that we're saying about ours now? It's too expensive, it's growing too fast. I think that is an interesting thing to look forward to. Two more ideas before we get into the reality. What you know, but it's important to remember, is that more of our healthcare today is spent through some type of insurance scheme, either by private insurance or a public program. It's still insurance. A third-party payer is paying for almost all of our healthcare today. So in 1970, we paid for most of our healthcare out of pocket. I don't think that's a good way to go. I don't think the care we got in 1970 was probably nearly as good as what we get today, but we spent most of it out of pocket. You see that with the federal programs, some expansion of private insurance. We spent more and more through some type of third-party payer. Until today, we spent almost all of our dollars through some type of third-party payer. That is primarily true for things other than hospital care. Hospital care has always been primarily insured, which it should be. It's episodic, it's this fortuitous thing that happens, and it's really expensive, so you would expect for that to be insured. But what's changed is that when we go to the doctor, when we go to the pharmacy, we spend almost all of those dollars through a third party, through some type of insurance, whether it's Medicare, Medicaid, or private insurance. And so the reason why I bring that up is you cannot solve the problems of healthcare, no matter who's paying for it, without dealing with the problems of insurance. And there are two major ones that keep people like Doug up at night screaming. And the first one is adverse selection. So adverse selection is that people who expect to suffer a loss will buy insurance more often and more of it than those who don't. So if I'm a reckless driver, which I like to think I'm not, although I did speed past Doug on 6th Street, sorry Doug, then I might well buy more auto insurance, buy a lower deductible. And so that in healthcare we have that as well. The second one is moral hazard. All right, which is a little bit more subtle here. So that means once I have that insurance, I don't mind parking my car outside in a rough neighborhood quite as much. Maybe I'm not quite as worried about speeding and maybe getting into a wreck because I know that my car will be paid for it. I like to think I don't behave that way. But the actuaries of the world know that that's what happens. So adverse selection, that's easy to think of in healthcare. If I'm sick, I'm going to buy healthcare more often, and I'm going to buy a lower deductible than I would if I don't think I'm going to have to use it. In healthcare, it's a little bit different, but it's insidious, and it's an important thing to deal with. We have to deal with it. So it's not that we are willing to be sick or injured more often because we have health insurance. None of us wants to be sick or injured. Where the moral hazard occurs is when the decision is made about what care to get, how expensive it is, what sort of therapy to get. That's where the existence of a third-party payer affects healthcare. All right, so we have a fee-for-service system, both in the public programs and in private insurance. And what that does is provides an incentive for more care and more expensive care. Now, last time I was here, I told a story about a sonogram that I'm not really sure that we needed for our third child, Penelope. And in the moment, I was not willing to say that I'm not sure we needed this sonogram, because I would love to, the fact that I was married and wanted to stay married. But I did think, I'm not sure this is great care. Actually, I'm not sure this is necessary. It was great care. It was great care, and we felt great as consumers, but I'm not really sure that we needed that in the moment. I don't really know. I'm not an OBGYN, but that's the thought I had, knowing how the system works. I am not saying that to villainize healthcare providers, because the fact is that you and I as consumers also believe that we're better off with more care and more expensive care. It's natural to believe that. If whatever's new, we automatically believe is better. And so that's the way the system is set up right now. So to deal with this cost issue, so my point here is that the ACA dealt with adverse selection, with the mandate, with the subsidies and so forth, didn't really deal with moral hazard. So to solve the cost issue, what we have to do is change from a fee-for-service system to one that incents quality and value. So you've probably heard these things called accountable care organizations, patient-centered medical homes, and so forth. These are things that try to get providers away from the fee-for-service system to paying for quality. And so we need to shift, no matter who's paying for it, whether it's the federal government or private payers, we need to shift the way that we pay for it to get better incentives. All right, one other idea before we get into the reality. This is a really important one. Healthcare spending is highly concentrated. We have to remember this. This is why it's so hard to solve. So this just shows the concentration here. We spend about a quarter of our healthcare dollars on 1% of the population. We spend half of our healthcare dollars on 5% of the population. And up until we spend almost all of it on 1/2 of the population. Now you all look, healthy and vigorous, and I'm guessing all of you are in this lower half where you don't spend as much on healthcare. We spend 3 cents of every dollar on that half. So the reason why I bring that up is that there's a lot of loose talk about if we can just, cut down on this or that around the edges of healthcare, we'll solve the problem. That's not what's going to solve it. Why this is so difficult is that we spend our money on people who really need the care, on people with complex chronic conditions, on people with cancer, on premature babies, on children with hemophilia. These are the really expensive things that are difficult to make less expensive, but we have to find a way to do that public programs and in private health care, or we're not going to solve this problem. So that, I say that just to show that I believe this is a really hard problem to solve, and we're going to have to work together to do that. All right, so the reality in healthcare reform right now, such as it is the Affordable Care Act. It is a three-legged stool, as is the cliche, and kind of a rickety one, but hey, it is still standing. It is you can still sit on it. So three things, and really four. Made healthcare available, so guaranteed availability. If you show up, we have to offer you care. We have to offer you coverage to show during the open enrollment period. All pre-existing conditions are covered. It's community rated, so everybody's in it together. They also expanded Medicaid in most states, not here in Kansas, to cover more people. It's now mandatory, at least it was, or will be up until next year. We'll talk about that in a second. There's an individual mandate. It's a relatively weak mandate, but you're supposed to get health care. But you can only do that during the open enrollment periods. If we're going to do that, we need to make it affordable. So there are subsidies to low and moderate income consumers. They're flexible. There are also cost-sharing reductions for lower income consumers. And finally, there's a consumer-oriented market. So there's this exchange or marketplace that actually works pretty well now, and standardized plans that are offered through that marketplace. So what happened? As you well know, it had a very rocky start, and that dramatically undermined confidence in the law. If you look at the charts of the approval of the law in October of 2013, it dropped dramatically because the exchanges didn't work out of the gate. But I will tell you, since then, there's been a much better experience for consumers. I hear very few complaints, really none, from consumers who use the ACA, who go to the marketplaces. It actually is a pretty good website, and it works pretty well if you're buying your insurance through the ACA. So about 8 million consumers enrolled for the 2014 policy year. A lot of them were uninsured beforehand. We know that from surveys. Only about 10.6 million are enrolled through exchanges today, which is not as much as they predicted. It's much, much lower. I think a variety of reasons for that. One of them is that there has been something of a stigma. It's become a political issue. We know politics is so difficult nowadays that some people aren't interested in signing up for that, even though it's perfectly good care, I promise you. But the other thing is that the small group market has held firm in ways that we didn't expect. A lot of people thought, so the CBO, when they projected the numbers, they thought that small business owners would say, okay, we're not going to do this anymore. We're going to send everybody to the exchange. It's guaranteed issue. It's subsidized. They just haven't done that. So the small group market has held firm. Now about 12 million people, newly eligible, have signed up for Medicaid in a lot of other states. So a lot of the expansion and coverage has been through the Medicaid expansion. Now, what are the good things about it? Well, it provided financial assistance to a lot of Americans. It made health care available to a lot of Americans who couldn't have it before. We know that because the uninsured rate dropped dramatically from about 18% of the population down to about 10%. We're not there yet. Still about 1 in 10 are uninsured, but that's a big drop. We cut it almost in half. That is something I think that you should be happy about as a country if you believe that everybody should have health care, and I certainly do. And the fact is that people who have it tend to like it. So this is a survey in 2016 for people who had coverage. They tend to like it. They tend to believe they're made better off by the coverage. Now, one thing that I regret to say is that if you look at it, Democrats really like it, Republicans not so much. We need to get to a place in our country where we're all able to see the same thing the same way. We're not quite there yet. So that's an interesting thing. The other thing that I'll add this year, not from last year, is that it has stabilized. So there was a concern as the ACA kind of matured and frankly was poked with sharp sticks by certain people in certain places that it would fall apart. It actually has firmed up. We had big rate increases. We did because we were way behind on our premiums compared to the claims we were paying out. The concern was that the pool would fall apart. It didn't. So we actually had a lot of stability there, and there's a lot of reason to believe that if they keep it together, it will continue to work reasonably well for those folks. But it has some shortcomings. The first thing is that there were dramatic rate increases in early years, and I'll tell you why. It is because people were a lot sicker than we imagined they would be in the ACA pool. So this doesn't look like a big difference, but remember the concentration of healthcare. 4% of the people in the ACA pool, I think it's 2015, reported themselves to be in poor health. Only 1% in the rest of the individual pool. That doesn't look like a big difference, but it is a huge difference when you know that we spend almost all of our money on people who are in poor health. So that is why. So people underestimated the amount of claims that would have to be paid out in that pool. So as a result, some raised rates. That's what we ended up having to do. Many dropped out, and so there were a lot of places, as you can see, that have fewer. There are fewer places that have 3 insurers, more places that only have 1 or 2. We have always had 2 in Kansas, and I think we'll have 2 next year in Kansas, which is okay. It'd be better probably for consumers if there were more choice. We've been the only company that's been in it all the years that it's been open. Okay, and it remains controversial. This is something that we, again, someday I hope we'll have a healthcare system that everybody supports, that we all feel good about. We're not quite there yet. So this is the Kaiser Family Foundation does this poll. You can see there have been times when it's been relatively unpopular. It's more popular now. This is October of 2013 when the exchanges didn't work. It dropped. Over here in 2017 is when the Republicans introduced their bills. All of a sudden people thought it was better when it was presented against something else. And so it is about 50 to 40 now, favorable, unfavorable, so for what it's worth. Okay, so the Republicans did do some things in 2017. They tried to alter reality, and they did to some extent. So you remember that last time I talked to you, they were introducing certain bills that, generally speaking, would have repealed the individual mandate, would have reduced subsidies under the ACA, and rebalanced them away from older and lower income Americans toward younger and relatively higher income Americans, would have returned some of the regulatory authority and spending discretion to the states, and would have phased out some of the bills, the Medicaid expansion. These were not popular bills, and they actually helped revitalize some popularity of the ACA. So they failed narrowly. You remember John McCain, God rest his soul, with the thumbs down in the well of the Senate. So none of them passed. And it actually, if you look at Republican approval, President Trump's approval, it hurt them both there while that was going on, because there was a perception that it was going to undermine protections for certain things like pre-existing conditions. So those failed, but things did happen. So one of the things is that the Trump administration canceled payment for the cost-sharing reductions. Now, there still are cost-sharing reductions in those policies. So we're still, as insurers, required to lower cost-sharing in silver plans for people of a certain income. We just don't get reimbursed from the federal government for doing that. So the insurance companies had to eat it initially, and now they just build it into the rates. So it didn't really change what was going on there. But they did put fewer resources toward ACA promotion. I don't think it's had that big of an impact. Some people have complained about that. But one potentially big change is that in the tax bill that passed at the end of 2007, they changed the number for the tax penalty for the individual mandate to 0. They didn't change any of the language. They just said the number is now 0. So the question is, what effect, if any, will that have on enrollment in 2019? And we are relatively skeptical. We don't think they'd have that big of an impact on enrollment because it's a relatively low penalty, but we'll see. That's something we're going to find out next year. But HHS still runs the law. There's still career bureaucrats there who perform audits, who perform all the work that underlies the ACA, and they do a good job of it. They still support the law, and it has remained relatively stable and relatively functional. We'll see what happens in the years to come. Okay, but there is a new reality coming soon. AHPs and short-term limited duration products, there are new regulations that were issued this year on both of these issues. These are potential solutions for some consumers. So AHPs, these are association health plans, makes it easier for employers to form associations to provide health benefits to their employees. They can do it on a common industry, so the National Peanut Shucking Association or whatever, or geography, so the Nebraska Business Association. What it does is give those small employers both the benefits and the risks, because there are risks in the large group market. It's not all milk and honey. There are problems in the large group market, a large group plan. They can get some economies of scale, potentially some stability in their rates. But the problem is with associations, and we run a lot of associations here in Kansas, adverse selection. If you're a relatively sick plan, this may look good for you, but if you're one of those that's relatively healthy and you have a bunch of sick plans and join your association, there could be instability in the pool. So that's something to keep your eyes on. It also continues to be subject to state regulation. To take advantage of this, the state would have to change state law on some of these issues here in Kansas. Short-term limited duration products, this allows up to just under a year, so 364 days, a short-term product that is not subject to some of the protections of the ACA. So they could be underwritten. We don't currently offer these products. I'm not sure we're going to. I don't think they'll actually get a whole lot of take-up around. There are a few plans around the area that may offer these, but I'm relatively skeptical. Either of these is going to have a big impact on what's happening in healthcare. So, all right, well, I know it went really fast. Just a minute, so I've got literally a minute left. Actually, good.
That clock's fast.
Oh, that's fast. Okay, I was going really fast because it's almost running out of time. I'm just going to stand here for a while. All right. So politics. That's why I was talking so fast. All right. So guess what? this isn't over. So what I would say about politics is that the politics of this issue are deeply, deeply unsettled. In some ways, more unsettled than they've ever been. There is a lot of pent-up energy on both sides, but I think more among Democrats than Republicans right now on healthcare. And so this debate is going to continue into the next decade, certainly, and it's going to be a big issue. It's a big issue right now. It's going to be an even bigger, I think, issue in 2020. This is the latest released Kaiser poll on what people care about. So the Kaiser Family Foundation is a treasure trove of great information on healthcare. So I recommend, if you're interested in health reform, go there. There's a lot of data you can see. What this shows is that it's the second of the issues they mentioned here. It's the second most popular or most important issue among the voters that they polled. So what I would say about this poll, this was in August, and so you can see that the Supreme Court nomination was way down the list. August was a simpler, more innocent time. So when they released the October results, I don't know what to say. But, so this is a big deal. I don't think Republicans are going to revisit it in 19 and 20. I don't. If I were advising them, I'd say focus on other issues. This isn't in your wheelhouse. I could be wrong, and they may well come back to it. But I'm guessing though. So this is to my third point. That we're going to have a debate. Maybe that should say by 2021. Certainly thereafter we will. But it's going to, the terms of the debate, what's on the agenda, how it is framed, and whether there's any success will depend on what happens in the elections in 2018 and 2020. So I go to a website called 538. I don't know if you've looked at that. It's Nate Silver's kind of a statistician and does all sorts of predictions about elections. Right now, his model shows that Democrats have a 3 out of 4 chance of taking the House. Republicans have about an 8 in 10 chance of retaining the Senate. They may have to actually pick up a seat in the Senate. If that happens, then I'm sure Democrats will run a bunch of bills in the House, work a bunch of bills, and that will shape the debate dramatically. If it doesn't happen and the Republicans retain control, it'll be sort of more of a party in exile, but they'll still talk about it quite a bit. There is some chance that Democrats will win both the House and Senate and White House in 2020. I mean, I think that'll be a hard thing for them to do, but the map is really bad for Democrats in the Senate in 18. So it's really bad for Republicans in 2020. It kind of flips. Not quite as bad, but there are a lot of Republicans up in 2020. So just imagine that world. If that happens, then the debate on healthcare is going to look a lot different than it does today, and we're going to have a much different conversation. Here's what I would say. We've got to get to a point, whoever is in what position in those three things, the House, Senate, and the White House, where we have an adult conversation about healthcare. Because it's hard to imagine anything more important. I suppose we can talk about, I don't know, maybe global warming and terrorism or something, and some sort of existential issues that are more important. But to our economy, to our quality of life, to our ability to live the kind of lives we want, it's hard for me to imagine something more important than getting healthcare right, than making sure, however you do it, whether it's bigger governmental programs, better regulated and better run private systems, some combination of both, which is probably where we'll end up. We've got to do it better than we currently do. And it's the reason why I'm in this industry. The reason why I've been lucky to have a job, both in government and now in the private sector, on this topic, is because I'm passionate about it. And I think probably in 5 years the system will look kind of like it does today. It might well look something like it does today in a decade. But I'll bet you in 20 years it looks a lot different. My hope is whoever's paying for it, whether it's through taxes in a government program or through the private sector or through a combination, is that everybody in the country has access to affordable health care, because nobody should go bankrupt because they get sick. Nobody should have to worry about being able to pay for care that they need. We are too good of a country. We are too advanced. We have too much going for us to let this go on forever. So my hope with all of you is in the years ahead that we can all work together to get there. And it's my privilege to be part of it. So with that, I had a few more minutes than I thought. I wouldn't have spoken quite as fast. If there are any questions, I'd be happy to stay after or answer any right now. I don't know if I still have time to do that. 2 questions, okay. Yes?
I'm glad this is with 2 hospital administrators who both said the only way to drive healthcare costs down is to have a single payer. What's your thoughts about that?
So there's a lot of reason to believe, I understand why people believe that. But the fact is that some of the best systems in the world, probably the best systems in the world, aren't single payer. The German system has a public side, has a private side, it's a relatively complicated set of payers, and they get this right more often than not. Switzerland, I said, is gaining on its some. They have what is basically, Switzerland and the Netherlands have basically kind of a less controversial, better regulated version of the ACA, kind of, where it's mostly private payers, individual policies. And you can run a government program poorly. You can have runaway costs in a government program. And the fact is that the costs of Medicare and Medicaid are also unsustainable. The cost increases there. So I think it's a false choice. We can get this right with a private system, a public system. We just have to do it better than we currently do. The other thing I would say is it's really easy to say we're going to have a single payer system and we're going to pay everybody Medicare and that's going to fix it. Be careful what you wish for. There are, because that is a big change to what is currently the biggest industry in this state. Healthcare is. So right now, and I'm not saying this to scare anybody, I'm saying this is what would happen. If we decided we're going to turn on a dime, or let's say we turn on, I don't know, 2 quarters or something, so it's over 5 years. There are doctors, there are nurses, there are radiologists, there are janitors, there are secretaries whose salaries, whose livelihoods are based on the current system being paid at that current level. My point is, if you change to just paying everybody Medicare, there's going to be a lot of disruption. I don't think that's probably the right way to go. I think probably the right way to go is to find a way to use our current system, but just do it better than we do. But that debate's coming. That debate is coming, particularly if Democrats win in 18 and 20. That debate is absolutely coming. My prediction is that it won't be the full Bernie Sanders model. It'll be somewhere in between where there's an option, there's a buy-in, there's something like that where people can join a federal program. That's my prediction, if that happens. Yes, Joan?
I want to go back to your moral choice.
Yes.
Because one of the things that I think is fascinating about this, we use too much. Maybe you didn't need the sonogram. What our system is built, if you look at the malpractice side, to do everything you can to make sure that you don't make a mistake. What changes would you see we need to make to limit that overutilization? Because that's where much of the cost is.
Sure, Joan, I'm actually relatively skeptical about the effect of malpractice cases on care today. That may have been true in decades past, but there's been a lot of reform, and it's actually a relatively small part of what happens, defensive medicine. And so I do think it's more just the overall incentives in the system. And I, again, I will never villainize providers for trying to run a business in a way that's good for their business. And I do think that Topeka in particular has great care. We have great doctors. We have really good hospitals. We're lucky that we still have 2. And that's a great thing. And so I'm a big fan, frankly, of the healthcare providers in here, but we need to give them a system that gives them the right incentives so that they give the care that is good for consumers in a way that is sustainable from a cost perspective. And here's what I have found, and I know Doug works with a lot of these providers as well on the physician side. They want a system that's sustainable too. There is a lot more enlightened self-interest out there in the healthcare system than you might realize. And so what we find is that there are a lot of very willing hospital administrators and doctors who want to get to a system that is sustainable. They understand that it still costs too much, and they see it in their patients. They see it when they can't pay their deductibles. They see it when they have to chase bills that aren't being paid, and it bothers them as much as anybody. So to get to your point, I don't think it's defensive medicine so much as I think it's the overall incentives that the system has. We can fix that. We can make that better. Thank you.
A couple of things for you. 4-way test point. That's a credo that we live by, and have a lot of folks in our club who are great examples of that. Doug is one of them, and we would encourage you in that. Live your life that way, and when you meet somebody else who's doing that, pass that on as well.
Awesome, thank you.
Instead of a bad pen or something else, we ask you to sign the book plate on that book. We donate those to the Ross Elementary School Library, so sign that for us before you go if you would. Thank you again for your time. Let's all give Karen and Zach another round of applause. end of meeting announcements. Next week, we're back at the Ramada, and District Attorney Mike Kage will be there as our speaker. So with that, let's stand and say the 4 and a half-way test and adjourn. Of the things we think is fair to do,
Is it true? Is it fair to all concerned? Will it build goodwill and better friendships? Will it be beneficial to all concerned? And will it be fun? So good that you're joining us. Thank you.